Thank you. So during this session, we jumped from the pelvic floor to the heart. Now we are jumping from heart to the brain, which is in fact the most important sexual organ. And also this kind of interdisciplinary collaboration between urologists, endocrinologists, and psychiatrists today. So I'm going to talk about psychotropic medication-induced erectile dysfunction, no relevant conflict of interest, and my objectives are to review the whole burden of the psychotropic medication-induced ED and to dig a little bit into the mechanism and provide you with some tips on assessment and management strategies. So the assessment of psychotropic medication-related sexual dysfunction is not an easy task at all. Firstly, because of the complex interaction between disease, the physical health, and medication-related risk factors. Secondly, because we can assess the separate pathway of each sexual dysfunction, but still there is a complex interaction between desire, arousal, and orgasm. And affecting one of these can also affect all the others. And there are also some concern I'm going to talk about the quality of evidence. So let's start first with these complex interactions. Mental health problems are among the top 5 causes of disability worldwide, and it's around 1 in every 5 adults, in young adults and middle-aged adults that are suffering from mental disorders. So whatever specialty you represent, you are having many of these patients in your office, and commonly also treated with psychotropic medications. What about the somatic burden? In case of people with so-called severe mental disorder or severe mental illness, which compares for the recurrent depression, schizophrenia, or other primary psychosis, and bipolar, they are at much higher risk, at least like 4 times much higher risk of being obese, or they usually live from 15 to 20 years less than the general population. And that really matters. They have all these risk factors for cardiovascular disease, which are also relevant for erectile dysfunction, as you know. Depression is perceived as one of the top killers of sexual function, and in fact, it is related with decrease in all sexual function, including about 1/3 of men suffering from arousal dysfunction. In case of psychosis, you'll find that even people with first episode psychosis, yet untreated, will have an increased risk for sexual dysfunction as compared with ultra-high-risk group and general population, which is the case for desire dysfunction and orgasmic dysfunction, but not necessarily for erectile dysfunction. So there might be other factors involved, and especially the medication might play the role here. It's so much important, the central regulation of sexual response, and to understand the dual control model. So on the brain level, we have the key players, the 3 monoamines, serotonin, dopamine, and norepinephrine. And we got steroid hormones, which have the receptors in the brain, and we have neuropeptides. And especially regarding the monoamines, dopamine is the very important fuel for sexual desire, for attention to sexual cues and the sexual arousal. Serotonin is the main inhibitory factor, and it also affects indirectly the dopaminergic downregulation. And we live in a world when antidepressants are very commonly used. They are known already as lifestyle medications, the drugs that will wash your everyday troubles away. And in fact, in the first decade of 21st century, the prescription rate of antidepressants has more than doubled. And the most popular selective serotonin reuptake inhibitors are very commonly prescribed not only by psychiatrists, but all the other specialists as well. In fact, we have still deficient attention to the treatment-emergent sexual dysfunction and the paucity of long-term follow-ups, also when the treatment stops, and what happens several months or even years after the people have stopped, what kind of influence it has on their sexual function directly, but also on their relationship, and maybe in some of them even long-lasting sexual dysfunction after discontinuation. The data on psychotropic medication emergent ED is still limited because first of all, sexual dysfunction are commonly in this sort of study are evaluated more in general, or the data is aggregated for men and for women, so we cannot distinct it clearly. And the emergence of erectile or other dysfunction is evaluated by non-structured interviews or many non-specific checklists, which may in fact lead to underestimation of these clinical conditions. And there's still a concern on the quality of the evidence. But still, regarding antipsychotics, we see that the overall incidence of all sexual dysfunction, are also specifically arousal dysfunction, is high. The same applies to antidepressants. And here even more, because regarding arousal dysfunction, the most commonly used antidepressants will be related to even 20 or more fold higher risk of having this sort of sexual dysfunction. The data come also, much of the data come from the female samples, not only from male, so it's quite difficult to distinguish how does it affect male and female sexual dysfunction. But in this pooled analysis of RCTs that were investigating the association between ED and antidepressant use, not only ED, but other sexual dysfunction as well, but you could find that the data that comes from 11 controlled trials and the group of more than 3,000 of patients shown that the risk, the odds of having having erectile dysfunction is 2.28. And erectile dysfunction also listed among those side effects that are extremely difficult to live with for men, and sexual dysfunction are the top factors for treatment non-compliance. It is extremely relevant that we would ask directly about sexual dysfunction or use specified questionnaires, because if you rely just on spontaneously reported sexual dysfunction, you will recognize at least something about 25% of these cases. There's a very nice study from Spain showing on the high group of more than 2,000 of outpatients treated for depressions, many of them complaining of poor tolerability in terms of sexual dysfunction. So what were psychiatrists considering with those patients? They were, about 1/3 of them were considering to change the medication, which sounds really reasonable. But the other third would rather wait for spontaneous resolution of sexual dysfunction, which is not likely going to happen at all. The other strategies, including dose reduction, drug holiday, or drug discontinuation, may also affect the efficiency of treatment of mental health condition. So now about the mechanism. I would like to introduce with this three-level model, which first represent the direct impact on sexual dysfunction, and especially the serotonergic agonist, which serotonergic agonism is related with inhibition of spinal reflexes, which may affect ejaculatory function, but also on the central level, it decreases the dopaminergic activity. Together with dopaminergic antagonists, they would they will clearly affect the central inhibition of genital response in the medial preoptic area and paraventricular nucleus. And the third relevant mechanism is anticholinergic mechanism, which will cause decreased peripheral vasodilatation, which is so much important for the genital response. And here is in this table about antidepressants, you see with the red spots and dark yellow spots, especially the main killers of sexual response, including orgasm and ejaculation. And a very nice study comparing in functional magnetic resonance imaging, the brain activation in response to visual sexual cues So in people who use placebo or bupropion, which is a potent dopamine and norepinephrine reuptake inhibitor, so increases the activities of these two compounds in the brain, was related with properly increased activation of ventral tegmental area, an important element of the central reward system, and anterior gyrus singuli, which is important for emotional response processing and cognitive reappraisal. And in case of people who take paroxetine, this activation was clearly decreased, and paroxetine is a potent serotonergic drug, as probably you know. The comparison between the two most popular groups of drugs, SSRIs and the other one, selective serotonin and norepinephrine reuptake inhibitors, is showing that the both class of drugs have a profound effect on desire and ejaculation in men, but in case of erectile dysfunction, the definitely worst group are the SNRIs. But it's also been found that using atypical antidepressants is much more favorable for sexual function, especially using drugs like bupropion already mentioned, but also agomelatine, which is melatonergic antidepressant, or vortioxetine, for instance, which is modulating the serotonergic system, and it is also agonist of 5-HT1A receptors, which brings also which spares the sexual function by unblocking dopaminergic activation within the brain. Here is the impact of antipsychotics. So we also see a lot of red and dark yellow spots, so they also affect sexual function. In fact, the first generation, so-called classical antipsychotics, and here risperidone, which is an atypical antipsychotic, may strongly affect sexual dysfunction. And it is also, it's been found that it's related with dosing. So the higher dose you give, the more likely you will block the dopaminergic D2 receptors in the brain in the three major pathways, including mesolimbic pathway, nigrostriatal, and tuberoinfundibular, that will be related to different mechanisms of sexual dysfunction. So first generation and some second generation antipsychotics like risperidone, paliperidone, amisulpride are related with higher risk of sexual dysfunction, while on the other hand, the atypical antipsychotics, some of them are related with higher and some related with lower risk of dysfunction. Why is this like this? So that's how we come to level 2, which are the impacts of many other sorts of side effects, including neurological extrapyramidal symptoms, increased sedation, emotional blunting, or cardiovascular risk factors, especially weight gain, and hyperprolactinemia. And the modern atypical antipsychotics are so-called the dirty drugs because they act through many different receptors in the brain, and they are also related with different profiles of side effects that might affect sexual function. During the treatment, if even during the first month you see very slight, like about 5%, the increase of LDL or body weight, this is a very sensitive predictor of further complications. So we have to be very watchful for that. And even with these very sensitive markers, we have to react to preserve not only sexual function, but also cardiovascular risk factors as well. What about prolactin? Traditionally, antipsychotics were considered as sexual function killers due to their prolactin-raising properties. And in one study, it has been found there might be a certain threshold of 17 nanogram per milliliter, below which the risk of sexual side effects is considered as low. And there are also polymorphism of dopamine receptors, especially some of them might be related with lower risk of sexual dysfunction due to also lower treatment-related hyperprolactinemia. But still, these studies have not been properly replicated, so this level of evidence is still not so high. If you compare, for instance, two atypicals, antipsychotics, aripiprazole, which is partial agonist of dopamine receptors, and the risperidone, which act as agonists, you will see that aripiprazole is related to much lower risk of hyperprolactinemia, or even might decrease the level of prolactin, while risperidone the opposite. And aripiprazole, in fact, is related to much decreased risk, almost on placebo level, of sexual dysfunction. I know the time is running out, so just a few remarks on management strategies. So we have the patient that is diagnosed with sexual dysfunction, which might be related with psychotropic medication. What do we do? If the problem is identified as relevant and we can do something with that, so we can change the medication, we should follow the next steps. But sometimes the problem might not be so relevant here and now for the patient, or as a psychiatrist, we also have to care about the safety concern. So very often we must say to the patient, okay, for several months, we must still stay with this drug. But later on, there are several options, so we have considered these options for the future. And we might use groups of different treatments that are related with atypical mechanism and less of risk of sexual dysfunction. If it's not helpful at all, we might use some adjunctive medication. Not so many studies, but regarding the Cochrane reviews, we have the efficacy of PDE5 inhibitors in terms of restoring erectile function, especially in patients treated with antipsychotics or antidepressants. We might add on bupropion to antidepressant, or add aripiprazole to antipsychotic, or we might use all the other strategies that might not be so much evidence-based, but still now they are known as helping, like using lubricants, certain sexual aids, or sexual counseling and sexual therapy. So my take-home messages are that in fact, majority of psychotropic medication are really related to increased risk of treatment emergent sexual dysfunction. In the management of this condition, we should follow the pathway of the interdisciplinary collaboration and understanding specific mechanisms that might be involved. Some of them are direct, and some of them are latent or will appear in a longer time perspective. We also should consult patients on potential sexual adverse effects, or that even before starting with treatment, because they should understand the risk and the possible strategies to overcome this dysfunction. In terms of specific treatment, we might prefer atypical antidepressants and second-generation antipsychotics that are prolactin sparing in order to reduce the risk of sexual dysfunction. And we might use add-on medication like PDE5 inhibitors, for instance, in patients who have treatment-emergent erectile dysfunction. And combined treatment, if you use psychotherapy and pharmacotherapy, it's generally is much more effective, especially in terms of depression, but it also enables us to switch or to change the medication appropriately to decrease the level of sexual and other side effects. So at the end, I would like also to encourage you, come to Vienna. The scientific program will be real cool, and it's still time to submit your abstract, so please take this into account. Thank you very much.